on the council website. Apologies have been submitted by Councillor Paul Brandt, Joe Rafferty and Sarah Thwaites. Are there any other apologies? No?
Just noticed actually that Joe Rafferty has joined us after all. So.
Oh, right. Sorry,
Yes,
Joe.
that's all right, Wendy.
Well, not apologies for being here then. So item 2 is declaration of interests. Are there any interests to declare? No, thank you. Item number 3, minutes of the last meeting on the 1st of October, which are on pages 1 to 11 of the agenda pack. Are there any accuracy issues or other matters arising board members wish to raise on the minutes? No? Can we agree the minutes then?
Agreed.
Thank you. Item number 4, which is question time. Can I advise the board that a number of questions were submitted by a member of the public, but they were not within the remit of this board and therefore have been referred to the Health and Social Care Select Committee meeting of the 13th of January. So if we go on to item number 5, which is a COVID-19 update, which can be found on pages 12 to 29 of the agenda. As the response to COVID continues, it is key for this board to have oversight of the latest information, testing, vaccination rollout, etc., and the support available to our residents. This is outlined in the report on pages 12 to 29, as just said, and could I invite Matt to speak to this report, please?
Thank you, Chair. Hi, everyone. So, I'm sure colleagues have read reports. I'm just going to pull out a couple of key issues. So under epidemiology on section 3 of the report, obviously we prepare this report in advance, and so the data is slightly out of date in relation to the epidemic curve. So the report states the infection rate was around 89.6 per 100,000 up to the 10th of December. Where we are right now is our infection rate's actually at 143 per 100,000. The infection rate has continued to increase up the other side since we've exited out into tier 2. We maintained 14 days up until the 14th of December of a rate below 100 per 100,000, which was absolutely phenomenal achievement, exiting out of national lockdown into a tier 2 position after going into national lockdown in a tier 3 position. So it was a very strong achievement. Unfortunately, the nature of tier 2 controls is they're just not quite strong enough to stop the infection coming back up the other side. So the infection rate has continued to increase, and we're now at 143 per 100,000. The other bits I just wanted to highlight, Chair, were around the life expectancy under section 2 of the report, which I'm just going to get to now. And you can see, colleagues can see, slightly updated report from last time, but the data now shows 694 more deaths than recorded over the same period in the previous year, and 581 more than over the previous 5-year average. So it is a big impact on life expectancy as a result of excess deaths due to COVID during this period. And then, Chair, I was just going to highlight section 4, which is the asymptomatic testing section. And obviously, as colleagues will be aware, we've been taking part in a large-scale asymptomatic testing pilot targeted at certain parts of our community, very successful during the month of November, and now have a sustainable model in place, which involves around 12 sites operating, accessible to all of our community, and we are encouraging that the use of that smart asymptomatic testing offer as a way of keeping the infection rate under control as much as possible. Chair, I'm going to stop there, but I'm happy to take any questions on the report. Thank you.
Can I come in with one when Wendy?
Yeah, I did just call you, Richard. Sorry, did it not come through? Sorry.
Right. Okay, no problem. Yes, the numbers are back, I think, on the latest figures that I've seen today to 150. per 100,000 per 7 days, which is a huge leap. Have you any feeling, and I'm not asking you to justify this, but just use your instincts and skill to tell us how much further they're going to go if we don't do more to stop the activities which are leading to them? And secondly, I was disturbed that during the lockdown itself, that there were some businesses in town who worked within the letter of the law, but nevertheless insisted that all their staff came in when in the first, the real lockdown, they had been able to work satisfactorily from home. So I'm concerned that we might go into a lockdown nationally or locally. So I was wondering what we could do about it. Those two questions, please, Matt.
Thanks, Richard.
Thank you, Richard. So, yeah, I'm anticipating the rate continuing to increase. It seems to be going up at around 10 to 15 per 100,000 a day, and I think that's going to increase. And of course, we have got a bit of a pinch point around Christmas when people are going to be, even though there is strong advice and guidance out there, people are going to be gathering together, and that will inevitably result in the infection rate increasing further. It's a really difficult one because there is guidance around what people can and should do, and then there's human behaviour and what people do. And, you know, we can't, it is very difficult to stop people congregating. We are social creatures by nature, and that's what people like to do. The reality of the virus, of course, is that anytime people are in contact with each other is an opportunity for the virus to spread. So I think we are going to continue to see challenges in our infection rates over the next couple of weeks and into January. The second point was around enforcement, I think, wasn't it, Richard, and people kind of following the guidance. So, you know, this is a hearts and minds thing for me. You know, we have guidance. There's things that people can do and can't do, and there's things that people should do and shouldn't do. But we absolutely have to get all of our community, all of our businesses, all of our parts of our city understanding that the only way for us to control the virus is by all of us minimizing that social contact. So I don't think you can enforce your way out of this. I think we have to have a hearts and minds conversation that everybody buys into, and that's all of our jobs to push that message strongly to our partners and key stakeholders. Thanks,
Matt. Jane?
Thanks, Wendy. Just a comment on the referral section in the report, Matt, that it's really crucial that we keep that in place, which obviously we're going to do, because that will give people the comfort to know that they can actually stay in and not go out too much, and therefore the transmission rate, hopefully we can get it back down again. And noting the majority of referrals were for support for food, and we're linking directly in and putting people in contact with citizen support scheme for cash grants as well. So the emergency financial support. So that's all great. So thanks for that.
David?
Hi, Matt. Hi, everyone. It was just a comment on the life expectancy issue and to highlight work that we've been doing looking at if you look at the graph on whatever page it is, on page 21, you can see life expectancy in stalling from around 2010 onwards, something that was highlighted in the recent Marmot report update. We've got a paper under review looking at the relationship between local authority spending and stalling life expectancy that we'll be able to report back on soon. And that is clearly fed into COVID-related vulnerability. Again, something that was highlighted in the Marmot report update.
Thanks, David. Fiona?
Just a couple of points on the vaccination section. Just a minor correction that it says that patients can attend a primary care network site of their choice. They can't. They need to attend the primary care network site connected to that their practice is connected to. And then on a question, Matt, that it mentions 16 pods of vaccination sites, but we haven't. That's not been discussed or agreed yet, has it? That's very early thinking, I think.
Apologies. Okay, sorry for any errors in there. We'll get that corrected in the notes.
Thanks.
Thank you. Thanks. Any further questions? No? Can we agree then that the recommendations set out in the report? Yep.
Agreed.
Thank you. Item 6, which was the research on population mental health. Joe Rafferty of the Provider Alliance referred to the research work undertaken to look at the effects of the implications of COVID on mental health. Joe originally was going to have to submit apologies, so we had deferred this to the next meeting. And obviously, because the information is going to be updated, it's still our thoughts that it should be deferred. Is that agreed by everybody?
Agreed.
Yep.
Yeah.
Yeah.
Cheers. Thanks for that. Item 7, social prescribing. Again, at the last meeting of the board, there were discussions on the broader range of support services available over and above standard medical interventions, and it was requested to receive an overview from the CCG on social prescribing. Claire, do you want to do your presentation?
Thanks, Chair. So my name's Claire Marnie. I work for Liverpool CCG, and we've gave you this update via a presentation. So there's a number of slides which I think Peter is going to pull up for me, and so I'm not aiming to cover everything in this presentation, but just to highlight the front end of social prescribing, the way into it, and the new resource that's coming in from various quarters, and the work that we're doing to try and make sure that it works together as a system, as a clear and simple and accessible system, and that it, importantly, that it reaches the people that it needs to reach. So so Peter's got that on the screen now. So from a health perspective, or from the social health model perspective, one of the main aims is to equip universal services or first level health and care services with access to support that can help mitigate the impact of risk factors and the risk factors relating to poverty and social exclusion, and to physical and mental health. So in other words, the social prescribing or the social health model, the primary purpose is to support people who are failing to thrive because they're likely to be suffering some type of financial hardship combined with ill health, whether or not that's mental ill health or physical long-term conditions. And then the second purpose of the programme is to make sure that we align existing and new investments so that we really max out on all the resources that we've got and make them work for us as a system. So the next slide, I'm going to talk about the enhanced social prescribing model, and this is the part of the system that the CCG commissions for the whole of Liverpool. And there's part 2, which is social prescribers coming into general practice. That bit of the system is commissioned. I'll say a little bit about that, but it's the primary care networks themselves that are shaping that bit of the social prescribing system. So part 1, the enhanced social prescribing model. I'm on slide 4 now. Our provider for the enhanced social prescribing service was won via competition by Citizens Advice, and it was set up in 2015 for all GPs and mental health services in Liverpool. And it's a rapid response. It's an enhanced service for patients, and it provides a response within 2 working days, which is really important if people are experiencing financial hardship. It's usually quicker than 2 working days. And it provides a social prescribing response which integrates social welfare and well-being. And national policy focuses on the well-being end of things, but because of deprivation rates in Liverpool, it's important that we think in a much more creative way about how we integrate social welfare. So on slide number 5, this slide just says, when we linked the data from citizens' advice with EMIS data and secondary services data, we looked at who was referred. In other words, were we reaching the right people? And there were more women than men referred, mainly working age adults, and of those, the biggest single groups could be described as single men, age 40 to 59, lots of long-term conditions, physical, mental health conditions, living alone on an income of less than £360 a month. And certainly in the early stages of this work, there was at least a 30% of referrals were related to people who were living on less than £360 a month. The other group that has been adversely affected, and the Council's cumulative impact assessment supports this, was middle-aged women on very low income, 0 hours contracts, requesting food vouchers. Again, lots of long-term conditions, mainly mental ill health and respiratory conditions. The next slide shows you some of the referral patterns, and I wasn't able to get an updated slide for this presentation, but if you see on the top line, in 2018 to 19, the service was receiving roughly around about 9,000 referrals a year from primary care and mental health services. And in 2018-19, the service started exploring with what is called the Wellbeing offer, so combining that welfare and the Wellbeing offer. In 2019, referrals more or less followed that pattern. They expanded their Wellbeing offer, and then when COVID came along, when we looked at it in month 5, we saw that referral patterns and need in the population had changed quite significantly. And I'll take you on to the next slide. So slide number 7. You can see that the part of the service that provides the social welfare offer has really strong outcomes in terms of self-assessed outcomes in terms of management of physical health, mental health, feelings of being able to make a positive contribution, reduction in fear and anxiety, very strong performance or good outcomes in relation to those. Less so in relation to, for example, feelings of reduction in social isolation at that point. Slide number 8, where you see the Wellbeing offer, the outcomes related to the Wellbeing offer were originally very strong in relation to feelings of reduction in sense of loneliness, and obviously, importantly, variable but still fairly strong performance in relation to physical activity, engaging in creativity. Then COVID comes along, and obviously those health promotion, the 5 ways to wellbeing, those kind of outcome domains, COVID has a huge impact on those. And we're continuing to monitor those kind of impacts, but we also know that referral patterns into this service have changed dramatically, and I'll say a little bit more about where we think we need to go next in response to the learning that is generated by this way of working. Okay, slide number 10. So now I'm going to say a little bit about what the primary care networks are doing in relation to wellbeing. So slide number 10, NHS England awarded what's called additional roles and responsibility funding to primary care networks, and that included funding for social prescribing link workers and health coaches. To date, PCNs in Liverpool have elected to use that resource to recruit an additional 30 social prescribing link workers. Each PCN will use those. The resource isn't evenly distributed, so some PCNs have decided to invest more than others, and they have a slightly different model, and they're working to different priorities. So the next slide number 11, that poses a challenge for the system, not because that diversity and that very distributed model, not because that isn't good, but because we need to make it simple and accessible for other partners. So I suppose one of the questions is, how do we do that? We have this enhanced social prescribing model with a very strong social welfare, anti-poverty strand, which we know is important. And we have this other fantastic resource, 30 new workers coming into primary care, able to provide support in relation to wellbeing and other other type of health promotion interventions. But we need to make it work together as a system. So slide number 12 shows you that we have a social health model strategic steering group membership, which is jointly chaired by Helen Bennett from the LPA and also Melissa Campbell from Public Health. So, and Helen and Melissa and colleagues like Kath Wallace and myself have helped bring together a group that we hope reflects the partnership approach that we're taking. And that group really has been important in shaping the priorities and also processing the learning as we go along. Slide number 13, one of the priorities that has been identified is that we need to make sure that this is a very accessible service and that it is responsive and that it is accessible to the people who need it most. So we think that we need some type of single point of access, or an integrated front door is what we're calling, for people who are not in general practice. So we're keen to continue to integrate the social welfare and the wellbeing strand as this, particularly because we know that poverty rates are increasing. And we know that there are risk factors. Those risk factors will remain, and that they have a long-term impact. I suppose a shorthand for thinking about who the target group is for this service, or parts of this service, is that it's really aimed at people below the threshold for social care, people who we think would fail to thrive unless we give them a hand up. And because of that, we've identified that we need to expand into different, and we need to adapt the model so that it is reaching other groups. When I described who is reaching the service, as it stands at the moment, it's great. We know that we're reaching people who have very low incomes and lots of risk factors relating to ill health. But for example, it hasn't been particularly effective in reaching mothers and babies or mothers with young children. So that tells us that we need to adapt the model, we need to think differently, and we have already started doing that. So there are new referral routes opening up from care line, prevention and early intervention service, secondary care services, from urgent care, cancer, respiratory services in particular, and as I said, health visitors, midwives, neonatal services can all now refer in. And we have, the CCG has, and various grant organisations have enhanced the resource that we have available to allow us to do that. So at the moment, we're working next year to increasing the capacity by an additional 4,500 referrals. The responsiveness, that we're hoping to start quality assuring that response within 2 working days more emphatically, and we think that there's some software that we can use to help us monitor that. And also because, I suppose my final point is, because we've got this hybrid approach. We've got a centralised service commissioned by the CCG, and as well as this distributed model. And the combination of that means that we should be able to work with the main providers to shift the resource to the places that we need to, depending on what's coming through. So if we need to put more resource into one area, we can. Slide number 14, I'm on to my last 2 slides now. Slide number 14. I certainly wouldn't want to give the impression that this is all done and dusted. It is an iterative process, and we've put quite a lot of effort into building an evaluation plan and resourcing and the evaluation behind this, which will start in earnest in January. And that is because we know that we need to adapt the model as we go along to the changing environment, but also to changing levels of resource. We have 2 main systems here, and they need to work together as one. But we also need to make sure that we're reaching people who are traditionally furthest away from services and who experience significant barriers in accessing essential services. So that question remains: what other referral routes do we need to keep opening up in order to take referrals in from other parts of the system? And this service really it's activated by professional curiosity. This service has worked because of GPs who ask questions when somebody turns up in their surgery saying that they want sleeping tablets because they can't sleep, and it's that probing, you know, what is getting in the way of sleep, what new anxieties does this person have. Okay, let's work with them with their health issues, but let's also make sure that if we can do something to reduce the strain of threat of eviction, or, you know, if you're up in court next week because you haven't paid your TV license, because then whatever the reason is, can we do something about that alongside the health improvement? So we need to keep adapting. We need to keep thinking about the people who would benefit from this service. So the final slide, this is broad brush. This is the roadmap that we have been working to since July 2020, when the strategic group really came together and started to kind of coalesce as a group. So we brought together, we started to create stronger governance arrangements around this piece of work, and to place much more emphasis on learning capture and you know, a critical review really of what we're doing. And that's when we started to detail the evaluation framework. So far so good. In October, the PCNs were in their recruitment phase for the new social prescribing link workers, and we're still very much in piecing those pieces together. We also recruited perinatal workers, so it opened up this service to health visitors, midwives, and we launched, we have some funding from the Health Foundation, a 3-year grant, £500,000 from the Health Foundation to help us evaluate this work, and to make sure that when we innovate, we're able to understand what the impact of those innovations were. In November, we started working on workforce development in partnership with the local authority. And we start again with the local authority, we started working on the integrated front door proposal and what would it look like. So we're in December now, and we're hoping that we will be able to operationalise or implement the integrated front door, start testing that out in February. There's a small working group of stakeholders and providers that have been set up to do that. And as I said, the evaluation, the research and evaluation programme that's underpinning this will go live in January as well. So looking forward to this year, next year, from the CCG perspective, one of the big milestones will be the reprocurement of the main provider of enhanced social prescribing, and that contract, we hope to have completed that reprocurement by 31st of March 2022, and we're still in learning phase. It's been a really, I think, effective and successful contract for us, but the context has changed, and we need to over the next 6 months, really, we need to review all the evidence that we've got, so that for the next competition, that we're coming from a very well informed basis. And I think I'm going to stop there and open it up for questions, except to just reinforce what I've described is the way into social prescribing and some of the supports that people get access to. Of course, there is a lot of the referrals. There are a number of referrals which flow towards the voluntary sector and community services, and there is some work, probably not enough, going into thinking about how we can support the voluntary sector to improve to expand capacity, because in terms of the referrals that come through social prescribing related to wellbeing, but I'm happy if people have got questions about that. I'm happy to point them in the right direction, and if they'd like to get involved with those discussions, the same. So,
thanks, Claire. Any questions, comments? Richard?
Well, it is a comment, and I'm sure those who've been listening to, or members of this board for some time, will know that this is the 7th Health and Wellbeing Board in a row where I make exactly the same point about the total inept failure of the CCG, the PCNs, to involve ward councillors in what we do. This has been going now for 5 years, and I can tell you exactly how many times any GP, anyone from the CCG, anyone from the PCN has come to me to say, for example, we're finding a series of problems in your ward, Richard, with men 55 and upwards, and I think that was one of the key areas identified in one of the earlier slides. Have you got any thoughts about who might help us with them? Have you got any thoughts about what the services that could be provided in the ward are, or the ones that are there who could be expanded? Not once has anyone from the health service had the courtesy to contact me as a ward member to discuss this. And I've got all sorts of ideas about how you could help, as every other councillor has, providing they care about their wards and are active in them, and most of us are. But what we have is, once again, the NHS institutionalising all this, creating complex roadmaps, taking on staff, when frankly there are better solutions which are community-based, where the work could be done much more closely using the ward member as the local champion. And there's just one other thing that I'd add to this, which might seem to come in absolutely from left field. We're in the process of revising the ward boundaries in Liverpool. And wouldn't it be good, as we've had these PCN areas imposed on us, which are supposed to work with the community, if we could, at some way in part of that process, see whether we could move some of our boundaries to match those of the PCNs, so we can create joined up, coherent decision making at a local level, and then coherent and joined up actions at that sort of local level. But if there's no interaction, and there isn't with me as a member, then that ain't going to happen. So once again, I must say I'm entirely disappointed by this report, no matter how many times I raise it, no matter how many promises I get that it's going to be different in future, nothing changes.
Thanks, Richard. I'll bring you back in a minute, Claire, because there's a number of hands up, and then if you do them, Jane, and then Tony Reeves.
Yeah. Claire, thanks for the report, really helpful. In terms of the social prescribing, obviously it's been in place for a long time and it's made a massive difference on the ground. And thanks for referencing the cumulative impact assessment that we did back in, I think it was the beginning of 2017, wasn't it? It was a long time away, and that was done on the cumulative impact of the Welfare Reform Act 2012. We're the only council to have done it. And it would be great to update that, but obviously we haven't got the resources at the moment. The messaging is still the same though, so you're picking up on single men particularly, which is very interesting because of the link there with often single men particularly will go to the GP, and as long as you said before, there is the professional curiosity, I think you called it, the listening hard by the GPs, then you've got that link with those single men who actually don't want to go anywhere else because they don't trust anybody else and they feel ashamed of going anywhere else. And I can think of a few people locally who have been linked up with myself, and they are the ones that see the local GPs. Also, thanks for picking up on middle-aged women, because again that came out of the cumulative impact assessment report. And that's particularly linked up with the housing situation and the bedroom tax, and the fact that the middle-aged women, so-called, or older women, who are absolutely key to the network of support that enables the other members of their wider family to work and work locally, and picking up the children from, or the grandchildren from the different care settings, etc. I mean, Richard makes a point about, please don't forget about ward councillors, because we are on the ground, and I know that you're aware of that. And I think we've had long discussions in the past about trying to link up the boundaries of wards with your health structures. That would make a big difference if we could really drill down to that and listen hard on the ground. The other issue is picking up about the Marmot report, but particularly the latest one, as you said, where he was talking about building back fairer, which was, I think, last week. And I think the issue is well, there's a couple of issues there. One is the fact that the present government didn't actually, although all parties agreed all the Marmot actions in 2010, beginning of 2010, the incoming government in May 2010 didn't then agree to ensure a healthy standard of living for all. If they did agree that, that would have made a huge difference, and we could have moved things forward on the back of that. I'm starting to talk about living income. So obviously we've got living wage, as we know, or the real living wage. We've got living hours now that the Living Wage Foundation have identified. And I'm wondering actually whether we shouldn't be talking wider than that, and talking about living income. And that would then mean that the stress levels, because that relates not only to, it relates to people in work and out of work, and as people are flipping backwards and forwards, or doing 16 hours, or they're 0 hours, or whatever it is. And if you go back to, I think it was Harry Burns in Scotland, who was one of the public health guys years ago, who said the lack of power and control plus unpredictability equals chronic stress and anxiety. If together we can ensure that we get fair employment and good work, and we have a living income around that, and the conditions of the housing are right, and the pressures are that the chronic stress and anxiety becomes acute, so people can manage acute stress and anxiety, and actually that's quite useful at times because it bolsters you and moves you forward. But chronic, obviously you die young, or die younger. So I just want to say thanks for the social prescribing model. It has made a massive difference, and also it's linked up directly into Poverty Action Group through Debbie Nolan, who comes through as well. So thanks, and of course we can always do more, but brilliant what's been done so far. Cheers.
Thanks, Jane. I'll bring Tony in, and then Claire, if you want to respond to those three comments.
Thanks, Wendy. I wanted to pick up the points that Councillor Kemp raised. All of this is done within the framework of the One Liverpool plan, which is a key part of the city plan. And with regard to how we build models of health and care in communities, rather than the more top-down system that we've all been used to, at the community end of that, the council plays a lead role. And I can't sit here and let my NHS colleagues get the stick for, and it's not a criticism of Councillor Kemp at all, but to get the stick for this not working properly with local members, when actually it should be the council, and that's my responsibility as chief executive to make sure that we've got those relationships right at a local level. I'll certainly pick that up with my colleagues and talk to Councillor Kemp and other and the rest of local councillors over the coming weeks and make sure we get this right. But I simply can't sit here quietly when clearly we haven't got something right on the ground, and we will work to get that right so that the crucial role that local councillors play in their communities can be properly reflected in the work that we do across the health and care system. And I just wanted to make that clear. Thanks, Chair.
Thanks, Tony. Claire? You're on mute, Claire, sorry.
Thanks for all your comments. I just wanted to add, just to amplify a few points. I hope I haven't given the impression that this is the only show in town. It is. I suppose we were coming from the perspective that, as much as 30, sometimes 40% of GPs' daily work relates to psychological distress, and often that relates to social difficulties, social risk factors. So we were very much coming from the point of view, what can we do to, I suppose, use that as an opportunity to do good and offer something else. So we're adding to something to the arsenal of resources that are available through the health system. That does not in any way replace or is in competition with any of the other resources that are commissioned separately by the council and provided by the voluntary sector. And we have worked through the groups like the anti-poverty group that Jane chairs, and that group was supportive of this way of working right from the very beginning. And because we absolutely know that we are just one of many offers, but this particular service is targeted at people who are very poorly and who are facing job loss, which may be connected to their illness, or they may be ill because they've got job loss, or they're looking at long-term employment. And when that happens, people are often, they have to go to their GP. And GPs, before 2015, they didn't really have anything to offer other than a signposting support. So I would just want to locate it as part of a bigger range of offers. And the second thing that I would say is that there is something about the fact that the CAB, because they have this case management system which allows them to compare the demographics. This particular service, is reaching people who are much poorer than the people who are accessing citizens' advice on the high street. And that is important to us because that suggests that people with poor mental health often don't engage because they're lacking in confidence, or they haven't got the wherewithal to sustain that relationship with outside agencies. So by moving the services closer to them, we think we get a better, we're able to reach people who are perhaps a bit more vulnerable than those who are using high street services. And that comparative data remains of interest to us.
Thanks, Claire. Jan?
Thank you. First of all, sorry, Richard, it's me that's made the promises, and I can assure you we would have been there if we'd have had the opportunity this year, but mass gatherings are certainly not something that we can accommodate right now. We've now got the patient and public participation group established as a committee now of the governing body with a lay member chairing it. And that is challenges us to think very differently about how we engage people very differently in the CCG. But as Matt said, some of this is hearts and minds, and we need to think very differently about how we do this going ahead. So apologies. I think we would have been a lot further along with the approach that we want to take had we have had the opportunity this year. But you'll know that we've been particularly distracted on managing COVID and testing. So apologies, it is a promise that we've made, and we will rectify it.
Thanks, Jan. Jane, you've put your hand up again, yeah?
Thanks, Chair. Just a sideways one to this, that the GPs will be picking up because they often get asked for letters on this, and the social prescribing people will be picking up as well, and it's where it goes, and it's the issue of housing disrepair. And it's not only, sadly, private landlords, it's actually a lot of housing associations now. And GPs are under massive pressure, I know, because I send our resis to them and my local constituents, sorry. And until there is a real push back onto the housing associations, as well as obviously landlord licensing, if we can get that through with the private landlords, children particularly are struggling with respiratory problems that are exacerbated by the conditions in the house, particularly mould. and also skin disease, and also anxiety by the parents and carers because they can't move from those properties, because on property pool you can only get disrepair there every so often, and you have to prove disrepair. And actually all that happens is the housing association come back and say, well, we'll be doing it, or we've done it, and it's becoming a greater problem. And I wonder whether this is where actually the whole sort of social health and determinants of health link up with what's really happening in people's lives, and that can either lift them and help them to keep going, or it completely crushes them. So I think, Claire, if we could have a link up with looking at what's coming through and looking at the analysis and saying who's actually pushing back on the housing providers. Obviously it links up with rent arrears as well, but there's a specific thing where the housing association particularly can lift this up and sort out their housing disrepair. I know they're under pressure, but aren't we all? Thanks very much.
Thanks, Jane. I can't see anybody else with the hand up, so the presentation is for noting, obviously taking on board all those comments around consultation with all partners, including local councillors. Is that agreed? Yep. Thanks. If we move on then to item 8 of our agendas, which is Liverpool Sexual Health Needs Assessment. This report on pages 42 to 50 of the agenda provides us with an overview of the refreshed needs assessment, which provides an evidence base to support policymakers and commissioners, both within the City Council and local NHS, to ensure that services and local provisions meet the need and address the inequalities. Matt, can I invite you to speak to this report, please?
Thank you, Chair. So good sexual health is an intrinsic part of good overall physical, mental and emotional health. Most adults in Liverpool are sexually active. Sexual health is an important public health matter, and we know that poor sexual health can significantly add to the burden of disease in the local population with diagnosed and undiagnosed sexually transmitted infections. There's a number of recommendations in the report, and I'm just going to pull out the overarching ones, if that's okay, Chair. So firstly, to commission an integrated all-age sexual and reproductive health service through one Liverpool City Council contract as soon as possible, and with the service providing system leadership and delivering a range of services, including education, prevention and clinical interventions targeted at those most at risk of poor sexual and reproductive health. Secondly, commissioners should use a whole systems approach to sexual and reproductive health commissioning to mitigate against the profound impact of the Health and Social Care Act 2012. Thirdly, commissioners are advised to use a single funding mechanism within integrated services and consider how to mitigate provider and system instability that results from shorter tendering rounds. Fourthly, develop a sexual health strategy for Liverpool and ensure that this engages and integrates the whole sexual health system, has clearly defined priorities, roles and responsibilities, and considers sexual health across the whole of the life course. Fifthly, to ensure Liverpool residents have access to the full range of sexual and reproductive health services via a robust digital or e-platform to improve access to testing and contraception across the whole of the city. Six, to ensure that any commissioned e-service is well promoted and its key benefits adequately explained to patients to encourage improved uptake. And seventh, to engage with potential service users to understand which aspects of an online service offer matter most to them and use that to influence this service design. There are a range of other recommendations in the report related to STIs, to HIV and to reproductive health. Chair, for noting. Thank you.
Sorry, Richard, you had a question or comment?
It's a question. I did a meeting last week, which was a national one, with organisations representing transgender communities, and they were concerned, with no evidence locally, so I do stress this is a national meeting, that transgender people find it very difficult because of some prejudices in the system to develop their way into to move rather into the proper advisory services they need. And I noticed, unless I missed it somewhere, this report doesn't mention transgender as an issue. and I just wanted an assurance from Matt that they are picking that up and are dealing with the transgender community specifically, rather than whichever gender they assign themselves to.
Thanks, Richard. Any other comments before I bring Matt back in? No, Matt, did you want to respond to that?
Only to say, to give Richard the answer that yes, of course we will, and I'll provide you a fuller response on how we do that. But yes, absolutely, Richard, that'll be part of the planning.
Thanks. Is it agreed we note the report? Yep. Thanks, everybody. Next item 80 is number 9, which is the Better Care Fund submission 2020-21, and I know we're almost in 21. As people are aware, the Better Care Fund provides the mechanism for joint health, housing and social care planning and commissioning, and the report received today is the final approval stages as required under NHS guidelines, having already been approved by the CCG governing body and the City Council's Cabinet. The report is on pages 51 to 58. To speak to this, please.
Yes, thank you, Chair. I was just going to say that obviously the report is somewhat delayed, largely due to the fact that what's been going on nationally, we were waiting the national guidance before we could take it both to the CCG board and through Cabinet, which that's now happened. This is the first Health and Wellbeing board that we could then get it to after that. Effectively, in many ways, it's a rollover year, that there was no changes made nationally in the guidance. Given everything else that's going on nationally, we've retained the schemes that we had before. We obviously published this to explain how the funding is being used and detail as is set out in section 2. Therefore, there's a couple of key recommendations, which is around approving this, and then the section 75 and the expenditure plan that goes alongside it. Unless anybody wants to raise any details on the particular issues, I think as the Chair has pointed out, as we're 3/4 of the way through the year, this is the same issue that's happened everywhere. It's a bit an area which I would suggest isn't going to benefit too much by scrutinising at this particular point in time, unfortunately.
Thanks, Martin. Any questions or comments? No, can't see any. Are the recommendations set out in the report agreed then? Yep. If we move on to item 10, which is the standing item on the agenda, to receive updates on subgroups of the board and other governance matters. I'll invite questions after the first 3 updates have been given. So the first is an update on the Health Protection Board. And Matt, if you could give us a verbal update on that board, which does meet weekly.
Yep, Chair, the Health Protection Board continues to meet weekly and discuss mainly the issues around the pandemic. So it takes updates on the epidemiology and including the actions we've got in place to control the pandemic around testing, contact tracing, support for people being asked to self-isolate, our communications and engagement strategy, and so on. We've also started to talk about the rollout of the COVID vaccination as well, including the way that we are trying to develop a whole systems response to the vaccination. Chair, we will continue to meet weekly and report issues up to the Health and Wellbeing Board as they arise. Thank you.
Sorry, flicking between my screens, so obviously need to come off mute then. If I could get Jan Ledwood, please, to provide a verbal update from the Liverpool Integrated Care Partnership.
Thank you, Chair. Yes, we had a meeting yesterday. We've been concentrating on progressing delivery of One Liverpool, although, as you will understand, hampered this year because of the pandemic in most areas and in terms of our operational plan this year, but have progressed in others, particularly in areas that have been digitally enabled. We've also encouraged and facilitated the development of integration from a records point of view with the CIPFA work that has supported the testing that we've been doing across the city. And we were also considering yesterday the paper that NHS England's published that went to their board on the development of the integrated care system at Cheshire and Mersey level. It's a national paper and sets out timescales and ambition to work to progress the integrated care system approach nationally. So there will be a draft produced in response to the Integrated Care Partnership Board's view on that paper, which will be submitted to NHS England. We've not completed that piece of work yet, but the deadline for submission of that response will be the 8th of January. But it'll be a great... Tony, I don't know whether there's anything...
Jan's frozen there, but no, I just support what Jan said. There's a lot of work going on. I think it's really, really important that as we come through the pandemic, we position Liverpool to really move forwards with that focus on reducing inequality and improving health outcomes and contributing to a more inclusive and prosperous Liverpool, which are the key objectives, of course, in the city plan. That whole issue around inclusive growth.
Thanks, Tony. And thirdly, can I call on Martin to report back on the joint commissioning group, please?
Yeah, sure. A lot of work been progressing on this area. I'll just give a few highlights around some of what we've been doing. Fundamentally, creating a single commissioning function is the direction of travel. We've been doing work in the council itself, but also across with the CCG, in particular using the One Liverpool plan as a subset of the city plan as a blueprint. Working on the basis that everything is in, so looking at the subsidiarity of the budget being in Liverpool. It links around having a strategic commissioning focus on key segments, and then looking at how we bring our leadership together. So we look to, instead of duplicating and having a health team and a social or a council team looking at particular issues, how we can bring them together. We're developing an integrated business plan and looking at how we have a joint commissioning plan in place with a programme to support it, and how it will be developed for April 21-22. Obviously, there may be some changes yet in legislation, but that's going to be, I would assume, to be later in the year. Particular segments, just to remind people, is we're looking at particularly healthy, how people stay healthy in both adults, children and families, long-term conditions, disabilities, complex lives, which includes things like homelessness, addiction offenders, mental health, and around frailty and dementia. We are then looking at how does this help us drive better outcomes, because we know that some of the funding that we're spending at the moment isn't delivering the outcomes we want. We know that the funding that we've got is going to become more difficult, and we need to make sure that we're flexing our contracts, particularly working with some of our providers around what are the outcomes we want today. We set up a whole range of projects, project groups around some of those key areas. I mean, being able to have a plan around those developments. So we've got around 18 different projects which we're taking forward with nominated leads and a time frame. But one of the key things that we're seeking to develop further is an outcomes framework with a dashboard which we can report back into the Health and Wellbeing Board around those segments and around the outcomes that we're achieving. And we can link to that then the funding and the needs assessment.
Thanks, Martin. So I'll take questions on all three now. Richard?
My question, or comment rather, is really on the second one. Tony Reeves laid out a very powerful reason for integrating health into all the social determinants of health in our city plan. I am extremely worried indeed that our ability to achieve that will become much harder within the new proposed ICS system. As it happens, I just signed off the LGA's response today. We'll be talking about geography, for example. So Tony is going to try and shoehorn into a system which goes from Southport to Macclesfield, a Liverpool proposal. So we've got no idea yet of how the ICSs will give a lower level of consideration, so that there's the granularity that Tony was talking about. But the borders are nonsense. And in fact, Macclesfield, for most of its stuff, actually works with Greater Manchester, where its acute hospitals are, if I can put it that way. And it seems to me that we ought to be very, very clear what the NHS is doing. They call it a devolution proposal. Actually, it's a delegation proposal. It's a delegation to a recreated, smaller regional health authority. So I think we have to be very bold about saying that a lot of what is being proposed is wrong, because it's being done for the wrong reasons in the wrong way, and I think is likely to freeze out many of the interactions that everyone at this meeting hopes would and should take place between local authorities and the health system in their area or just outside there. We can't do everything in Liverpool, we don't expect to. But how do we do things at the appropriate level? Certainly ain't something which links Southport and Macclesfield.
Thanks, Richard. Tony?
I seem to be responding a lot to Councillor Kemp this afternoon. But look, first thing to say, Liverpool as a health and care system, it is on record as saying that we believe the appropriate footprint for commissioning is North Mersey. That is Liverpool, Seddon and Knowsley. Patient flow data, in our view, supports that. We've made that point consistently. At this stage, it looks like that argument isn't going to win the day, and that at the moment the NHSE intent is to create an ICS, integrated care system, footprint around Cheshire and Merseyside. But what we have been, rather than just sort of saying we fundamentally disagree with that and burning all of our bridges in arguing for that, we've been making the case very strongly that by far the most important part of this is the place-based activity, and that we need to influence that and, if you like, keep our powder relatively dry to win that argument. And that in fact, I was in a discussion with the chair of the Cheshire and Merseyside Partnership about this just yesterday, and that the default position should be that things should be determined and commissioned at a place level unless there is an overriding reason why it would be done better at a Cheshire and Merseyside level. I have to say that same argument in my view would apply if we were working at a North Mersey level as well. And I believe, we haven't won that argument yet, but I think we are making real progress with that. And the critical thing for us, and we've talked to the chairs of the health organisations, we've talked to political leaders in the city about this as well, is the need to move our own agenda, focus on our city plan and One Liverpool plan forward at pace, and not wait for permission to act in terms of implementing that. It needs to work within a Cheshire and Merseyside framework, or if there is a rethink, a North Mersey framework, or whatever the building block would be. But that place-based Liverpool approach, if we're going to tackle the determinants of health, and as we keep saying, to avoid the situation where people like us in 20 years' time are having a similar conversation about the next generation of the same families in the same communities, because we haven't fundamentally changed the dial in terms of outcomes for those communities, then we need to do things radically differently. And we believe the way to do that is at a place level. And my view is all of our attention should be focused on getting that right at a Liverpool level, not in terms of building a wall around Liverpool, but making sure that we get those things right, because that is the way we will achieve the desired outcomes in the city plan and get the best out of this in terms of the things we talked about earlier for Liverpool people right across the city.
Thanks, Tony. I can't see any further hands up, so can we agree the strategy? Oh, sorry. the update is for noting on that. Is this agreed? Yep. Okay, the next item is the citywide strategy group for fairness and tackling poverty. And at the last board meeting, it was agreed to explore the option of using the strategy group as an advisory group to the board to assist in progressing the recommendations of the Marmot 10 years on report to help tackle inequalities in the city. The report and appendices are on pages 59 to 82, and to provide feedback on that agreement, Jane, do you want to speak to the board in relation to that?
Yeah, thanks Peter as well, Peter Seddon, for doing the report for me, because it frames it the right way for the Health and Wellbeing Board, and he gets this stuff, which is always helpful. Okay, so we had a good discussion at the Citywide Strategy Group. So the Bishop joint chairs that with myself. We've got a really good set of partners around that board, around that group. Sorry, it's not the board, around that group. They were all up for acting as an advisory group, if that would help out with the Health and Wellbeing Board on the Marmot principles, because we are obviously now a Marmot community member. The key thing is that we wanted to make sure that we could help keep the social determinants of health and health inequality on the agenda of the Health and Wellbeing Board. This is one way of doing it. It's not the only way, but it's one way of doing it. There's a relation to what Tony Reeve said before about a place-based approach. So with the Marmot actions around creating and developing healthy, sustainable places and communities, it links directly up with that. That links up with our Fair City policy, which was agreed at full council in, I think it was January, February 18, which again links up with Marmot and looks at the upstream and downstream. It also links up with Blueprint for Better Business, with the principles of purpose-driven business. David Taylor Robinson put in the chat before about the poor health being a massive driver for the low productivity levels, and that social determinants of health linkage is very, very strong. So I had a good discussion as well with officers internally about how this all links up with the city plan, and Tony made that clear previously. So and driving proportionate universalism through our discussions as well. I think the key thing here is to say that one of the things that we could do, which is under number I, which is offer a line of sight to the street from the communities, on behalf of the communities, but with them. Because the key thing for me is that the people most affected by social determinants of health are the ones that are listened to, but not only listened to, but they're involved in working out the way forward. We need their wisdom on the table, and we're missing a trick here. There are lots of groupings and officer groupings within the council and elsewhere and within health that are looking at that, but I think it would be a good place for us as board members to be able to hear some good examples of this would make a difference, this has been negatively impacted in our communities, this is a way through, this should make a massive, huge difference in terms of fair employment and good work, etc. So if people are happy with this as a way forward, then I presume, Wendy, that this would come under when you do the subgroups, we would have an update, but I would hope that every so often we'd be able to make it as a major item on the agenda as well. Thank you.
Thanks, Jane. Any questions? Jane? No, and yes. Oh, sorry, David?
Hi, Jane. It was one of the things that we discussed at the last meeting was the need for a refresh of the old Liverpool City region poverty and life chances strategy, and what would be the route and which group would have ownership of a strategy like that. It clearly intersects with the work that's going on around poverty in the group that you chair. It intersects with the city plan. It's got clear implications for health and the social determinants of health, but I'm not quite sure where something like that would sit and who would have ownership of a strategy like that.
I would say if it's a city region, it would be the responsibility of the portfolio holder within Liverpool City region in having a city region strategy. Obviously, if it's for the city, the Health and Wellbeing Board here, as well as the departments within the council. Jane? respond to that?
Yeah, I think it goes back to the placemaking and Tony's point about the city plan. I think we can make sure that we bring to that wider region how it works for Liverpool to that city, wider city region. I would be sad if it got lost at that wider level, and it can quite easily get lost at a wider level. But we have a unique probably position statement to share with them. The cumulative impact assessment that the city region poverty group did was basically ours, and they extended it to look at putting all the authorities together. So I think we have a place within that is unique and special. So I'd be keen to keep it as a Liverpool base and share it with the wider region, if that works.
Thanks for that, Jane. David, did you have a further question, or is your hand still up from before? Sorry,
no,
is it from before?
No, yeah, nothing further.
Cheers, thanks. And obviously we can make sure that those discussions about a refresh, David, are raised with the relevant people within the city region as well. So just on that update, can we agree that the strategy group be a formal part of the governance structures of the board? Yep, I'm not hearing any dissent from that, so I agree. So the next item is the next date of the meeting, which is scheduled for Thursday, the 11th of March, 2021. But just before we finish, could I actually offer my thanks to everybody on this board and to your respective agencies for the fantastic work that you've done throughout the year. It's been probably the most challenging year of all of our lives in respect of health and well-being on every sort of level, both in fighting, obviously, and trying to control the pandemic, as well as obviously trying to address those social inequalities which the pandemic has really brought to the fore. And I think on a positive note from that, a lot of the work that we have been doing as partner agencies across the years, that's really come into fruition this year because the issues we've identified and have been working with, particularly with our funding and around the most vulnerable in this city, have put us, you know, in a better place than others in really supporting those who are most vulnerable. Also, you know, thanking obviously all the councillors as well who've done fantastic work within their communities and to have that connectivity between the various agencies as well. So I hope everybody, I know all of us, you know, most of us will still be working across the Christmas and New Year period, but I hope that people do get to have some time off, albeit limited for some, given the developments that are happening day by day, and that you get to spend some time with your families, friends, etc., because I know they have been neglected on all levels throughout the year. So try and get some rest. The work that each and every one of you do is really appreciated by all, and I know sometimes it feels like we're going uphill backwards, but you know, we will get there, and this partnership approach and the way we've worked in the past and worked through this, I think has really kept us strong, and we're going to need that going into the new year, because we're going to have massive challenges that face our communities, both on a health and a social inequality level. So once again, on behalf of myself and the city, can I wish everyone a fantastic Christmas, and also, you know, going into the new year, that we do have that hope of better things to come. We have got some great plans going forward, and hopefully, you know, we'll be able to realise them a little bit quicker once that vaccination programme is up and running. So thanks everybody for your attendance today, and look forward to seeing everybody in March. Stay safe and well, and keep covering up, washing your hands, and no hugging and kissing over Christmas.